It's a real honor and pleasure to be in Egypt. We've had some real excellent talks this afternoon, and I'm very humbled to have been included in the session. I hope that this talk will serve as a summary of what's been discussed and what is available in 2024 and how we can really change the shape of patients suffering from musculoskeletal pain. I'd just like to dedicate this talk to a dear friend and a very legendary Egyptian interventional radiologist, Bassem Georgi, who tragically passed away last year. So this is for him. So Swelliok, where I work, is the largest elective orthopedic center in Europe. It's based in Surrey. If you ever would like to visit, you're most welcome. There's a lot of attractions, such as the McLaren factory, if you're into cars, and the research center, as well as the Mercedes-Benz World. And this is kind of like a Disney World for adults, you know, car enthusiasts. So you're most welcome. We also have the Royal Automobile Club as well. So we want to talk about the repertoire of image-guided procedures, and this has rapidly evolved over the last 20 years. MSK radiologists are really well poised to treat patients with bone and soft tissue pathologies, as we can really provide the full spectrum of percutaneous, minimally invasive procedures in the outpatient setting. And this is particularly of value with such a growing, aging population and advances in oncological care, which necessitate robust, novel therapeutic strategies and improve the quality of life for these patients who are living longer and longer. So how do we define basic and advanced? So I tend to think of basic procedures as those that most radiologists can perform, and often these are first-line treatments. So these tend to be of lower cost, and the clinician tends to follow these up. But for more advanced procedures, we need focused training, and this is something that, you know, I'd advocate these patients are admitted to hospital and then followed up from the care of the radiologist who's actually performing the procedure. Because here patient selection is crucial, and we've seen some fantastic techniques being shown, and these could potentially lead to second-line and even third-line treatments. So following the patient on their journey is particularly important to tailor your treatments to their care. So the spectrum of what we can offer with minimally invasive procedures, mostly with local anesthetic only, is really remarkable. And most surgeons can only dream of offering such care. So even with endoscopic procedures, there is an element of invasiveness, which we can avoid with minimally invasive techniques, which we've shown. So we'll explore some of these techniques, which have already been discussed with some cases. Most of us who do intervention perform epidural procedures routinely, and this utilizes 22-gauge spinal needles. These are inserted interlaminar, transforaminal, or caudal, using various approaches. We have moved, you know, from fluoroscopy to CT, and even now in 2024, we can do this radiofrequency needle tracking and ultrasound fusion. So this is all done in the outpatient setting, and we can reduce ionizing radiation to patients and provide equal outcomes. For facet joint syndrome or patients with typical paralumbar tenderness without radiculopathy, as we've talked about, facet joint injections or medial branch blocks are performed. Ozone therapy is also developing a following, and success really depends on appropriate patient selection. I can't stress that enough. So again, we can adopt various imaging guidance techniques to our advantage to provide the best possible outcome for each individual patient. And continuing on the spectrum of facet disease, perhaps more intermediate to advanced intervention, accounting for potential complications, is synovial cyst rupture. So below is a nice paper from Connie Chang's group outlining their workflow, and here the radiologist has a powerful role in helping potentially avoid surgery for these patients. You can either adopt the direct or indirect approach, both are shown here, where the joint is accessed and through high pressure injection, the cyst, you can appreciate, is ruptured, or alternatively, via an interlaminar approach, the cyst can be fenestrated and then aspirated. And we confirm this because you can see the contrast spreading into the epidural space, and the patient's symptoms are immediately improved whilst they are completely awake and on the CT table. Rhizolysis, I'll just touch on this briefly because it's very nicely covered, but otherwise known as neurolysis, is a neurodestructive procedure aimed at long-term chronic pain relief of facet or medial branch block origin, but can target any sensory nerve. So here we target the junction between the superior or articular and the transverse processes, and in the spine, radiofrequency is the most widely performed. But I like many others have adopted cryoneurolysis, as has been shown just now, as an alternative. And this is an effective technique with less intra and post-procedural pain. So we've demonstrated here with fusion, ultrasound case, but again, we use this for sacroiliac joints and other applications. Biopsy, obviously, is an essential tool in our repertoire. Percutaneous biopsy is more of an intermediate skill with a formidable learning curve, particularly for challenging lesions based on the tumor characteristics and the location. But obviously nowadays, with novel biopsy needles such as this French system, which we've adopted now in our practice in the UK, vertebroplasty and ablation, and even osteosynthesis, as also has been shown, we can offer this through the same access trocar in the same interventional session. Also, briefly touching on discography, it's a useful technique to determine if pain is discogenic in origin and used in tandem with disc decompression methods. It's not routinely performed anymore, but still an essential tool for the spine radiologist. Mostly we perform this with fluoroscopy or CT guidance, but there is an emerging, exciting field with regenerative disc therapies, and the evidence year by year is growing with more FDA clearings for these procedures. Also, there are various decompression devices, thermal, chemical, or mechanical, and these are used to particularly or partially remove the herniated nucleus pulposus. In my experience, this has been mostly with mechanical decompression, which is a remarkable procedure, again permitting removal of the disc percutaneously under local anesthetic only with minimal tissue dissection. And this provides real-time qualitative and quantitative assessment. With endoscopic surgery that the surgeons are more and more adopting into their practice, you have a little bit of invasiveness still, so nothing compared to percutaneous procedures. We're currently writing up this data. We have over 200 patients followed up over the last decade, and we're really excited to share this paper with you soon. Briefly, to touch upon ablation methods, such as mentioned by Dr. Nassif, the challenges in the spine remain the proximity to neurovascular structures, but particularly the absence of a posterior vertebral wall or tumor entering the epidural space, because the cortical bone is no longer there to act as an insulator. So electrochemotherapy was also touched upon, which is again a new promising technique for these patients. Proper technique is therefore required with thermosensor insertion in the schematic that I've demonstrated here in the bottom left. And this is also described quite extensively by colleagues in Strasbourg and Ganji's team. Various insulation techniques can be used, injecting room air has also been discussed, and also CO2 and dextrose or saline. RF ablation is now standard of care thanks to Rosenbaum and colleagues for osteostomas, as well as malignant tumors and metastasis. So here we have an example of a solitary oligometastatic lesion treated with bipolar RFA, and in combination with vertebroplasty. And recently we managed to provide guidance to NICE and argued our case to have this approved in select cases. So based on current available evidence, this is now within NICE. There is also growing evidence of combination treatments coupled with radiotherapy, as mentioned in the previous talks, and also an emerging role for basivertebral ablation, as also that's been covered for the treatment of low back pain thought to be vertebrogenic in origin. For sclerotic lesions, cryoablation is more favored, but again challenging in the spine, so the ice ball may be monitored on CT in real time, but even better seen with MRI guidance. So challenges again include thermoprotection, and you can see here in the center image with the trocar in the epidural space, this remains a challenge. So offering cement stabilization also in these cases requires bringing the patient back, so allowing the ice ball to thaw or melt before we can physically put the cement in. I've just added a couple more slides because Dr. Nazi has shown some excellent examples of arterial embolization in the first talk, but we can also perform sclerotherapy. So this involves injection of a sclerosing agent, preferably in the foam state, to minimize the risk of extraosseous leakage, and it's a powerful tool when it's mastered by the radiologist. So here we did a study on the use in the spine, specifically treating ABCs, and this is a nightmare for the oncological surgeon and a true game changer for these young patients that want to avoid life-changing, debilitating surgery particularly. And this is a paper I did when I was on my fellowship in Oxford. So just in terms of injectables, if you look at the literature, we can appreciate almost anything you inject will stimulate the cascade leading to sclerosis, and more people are injecting bone-forming agents and even steroid. And apart from ethanol, if we focus on the main two, both of these drugs are proven effective, and doxycycline is a tetracycline antibiotic, whereas denosumab is a monoclonal antibody, primarily used for GCT and skeletal metastasis. But this is nothing new. So injection of a fibrosing agent has been first proposed by Adamsbaum in '93. There are various agents. The commonest is ethanol, cheap and widely available, and the mechanism of action of these is poorly understood. But it's thought that anything you inject will irritate and damage the endothelial integrity, causing this cascade of coagulation, thrombosis, fibrosis, and ultimately sclerosing the lesion. So again, this study we're using sodium tetradecyl sulfate, STS, very cheap, widely available, Fibrovane, again, that's been mentioned, 3%. And these have been around since the 1920s. It's only since our understanding of ABCs being these vascular malformations of bone has allowed us to adapt already established and safe treatments for these lesions. So just to show you, just added these slides last minute, so I apologize if I go over, but to create the preparation, you create 1 to 3 ml liquid, you take the STS, draw it up into a 10 ml syringe, and then you want to mix it with 3 to 9 mils of room air, draw that into a second syringe. This is all in the paper below, so you can access for free. And then we put it through the sterilization filter, which you attach there with the black arrow. Then the three-way tap is connecting the two syringes. And you want to create a small angle so you create turbulence as you do the injections. You then agitate it by mixing it with the air, by drawing back and forth repeatedly, about 10 pumps with each syringe. Then you want to have a homogeneous, smooth, opaque foam consistency. And this foam is then removed, and then we can inject that immediately within the lesion until resistance is felt. So it's important to check the quality and the consistency of the foam. Again, this technique has 3 steps. So using intermittent fluoroscopy or CT, we use a standard needle. We want to kind of burst the loculated cystic components until we have free-flowing blood into the syringe. We can aspirate that to dryness and then decompress the cavity. Step 2, we want to break down the loculations, creating channels into the lesion by entering the bone through various trajectories. We then inject contrast to ensure there is no intradural leak or passage into those large draining veins and the paraspinal vessels. Those are the concerns when we're doing this technique. And then step 3, we inject the sclerosant foam mixed utilizing that method I've just shown you. And we want to inject it from deep to superficial. So we want to draw the needle back and we allow it to settle for about 30 seconds. That was what we typically did. And then we would try to aspirate as much as we could. So we just wanted to coat that cavity. So here is an example where we published. We have an extensive spinal ABC involving the vertebral body, both pedicles, and extending along 3 levels from T11 to L1. Note the fluid levels, note the mass effect, thinning the cortex, and then molding the conus medullaris. So the latest follow-up MRI demonstrates significant response with reduction in the volume of tumor and remodeling of the T12 particle. But this did require 3 treatments or so over a 1-year period. Here we've got a 45-year-old female with lumbar back pain and left-sided radiculopathy in the L2 distribution, which was again diagnosed as an aggressive hemangioma. So we've had a case of this being embolized, but here we've done sclerotherapy. And just to show you, we did selective angiography and then we did sclerotherapy because of the epidural component. And then post-procedurally, with the CT images, you can see the extent of the coverage. And then we had to reinforce it with vertebroplasty as a combination treatment because we find more and more that these large aggressive hemangiomas tend to fracture and patients seem to come pain. So people say, oh, the treatment hasn't worked, but actually the bone is fractured. So nowadays we also provide supportive augmentation. Vertebroplasty is now considered standard of care for treating compression fractures, and the aim of both of these techniques is to consolidate and fill the vertebral body through cement injection, as we've seen, thereby stabilizing the fracture, and we want to prevent further vertebral body collapse, height loss, kyphosis, and ultimately to control pain. So recent studies also emphasize the role in preventing all-cause mortality and morbidity at 12 months. Both of these procedures may be performed with either fluoroscopy or CT guidance. The latter is my preferred method, as nowadays I can perform this with local anesthetic only, and I don't use a hammer. Balloon kyphoplasty, as we know, arose in the 90s. two primary advantages. You get slightly better fracture reduction, you also get improved control of cement, but the disadvantages include the fact that there is some loss of height when we deflate the balloon, and it's also much more expensive than vertebroplasty. We've also touched upon newer titanium mechanical implants such as spine jack, which is very expensive and not always justified compared to traditional methods. With Cummel's disease, we have the fracture cleft, and this represents non-union, and the aim is to create a cement bridge and fill this defect. So the patient's pain is immediately again resolved on the table, and this is one of the most satisfying procedures you can perform in the IR suite. Osteosynthesis again, or percutaneous screw fixation, is another rapidly evolving field, particularly in palliative oncology, but CT-guided sacroiliac disruptions can also be, this was first described by Nelson in 91. In 2024, we now routinely do these as MSK radiologists, particularly in France and Switzerland, and now I can see also here in Egypt. Other techniques include pars fracture fixation, and more recently the treatment of spinal stenosis, and these spacer devices are also gathering a lot of interest. Treatment of symptomatic spondylolisthesis remains controversial, but percutaneous screw fixation has proven effective, especially in the high volume centers that are seeing these patients. For screw fixation, you have this Kirschner wire in the pedicle through the trocar. Again, you can do screw fixation with a self-drilling, self-tapping screw. This is mounted over the K-wire, and the length is then selected based on the pedicle anatomy, so we can insert that then and we can remove the wire, and we don't need any skin sutures for these patients. So really, really, truly minimally invasive, and here you can see the final result, and the patient is home the same day. In cases of canal stenosis, we can insert an interspinous spacer, and this acts to distend the ligamentum flavum, thereby reducing compression of the cauda equina. In turn, this increases the foraminal spaces and reduces low-grade anterolisthesis. So this device can also be easily removed percutaneously if required. So if it doesn't work, it's minimally invasive, you have a very fast recovery, patient is normally home the same day, and the goal here is not to completely remove the back pain, but it's to reduce the lower limb weakness and improve mobility in these patients who have debilitating stenosis. We can also quantitatively assess the incurred changes with CT measurements, as you can see here. So we have increase in space, both discal and interspinous, as well as reduction in the protrusion. We can also quantitatively assess all of these factors with CT imaging. And here we have minimal posterior scar post-procedure as well. So I hope you can now appreciate the spectrum of procedures at our disposal in 2024 and what we can offer as radiologists. It's very key to have multidisciplinary working, so in all these cases we involve our clinicians and our surgeons, but we really need to take the responsibility of the patient, and that's really key for doing more advanced procedures to allow us to optimize our outcomes and tailor patient care. If you'd like to learn any of these procedures, I would like to invite all of you to London at our state-of-the-art facility next year, and hope to see you at the course. Of course, we'll offer Karam Masri for members of the Egyptian Society of Radiology and anyone who's attended, so just register your interest on the website. Thank you very much.